Assalamualaikum, good afternoon, and also good morning to our friends in the UK. I am Dr. Sharifa, your moderator for today's session. Welcome to the evening session of the Faculty of Medicine Research Carnival 2021. On behalf of the committee team, I would like to thank every one of you for being with us today, both on Zoom and also on YouTube live stream. So before we get started, all audience and on both platforms, please fill in the attendance. The link posted in the chat box, and there's also a QR code that you can scan, and these will allow you to enter the raffle, the lucky draw. So each and every session, we have 2 lucky audience that will win a 50 ringgit bread voucher. So guess what, guys? Your coffee is sorted for next week. So without further ado, let's go straight to today's events. Up next is a very important topic that every clinician and scientist will have to face before we conduct any kind of research, is ethics. Our ethics expert, Prof. Julia, will discuss the ethical conundrum in patients' involvement in research. A small introduction on our speaker. Associate Professor Julia Patrick Carson is a rehabilitation specialist, and she also holds a PhD in shared decision making. Her main field of interest is spinal cord injury rehabilitation. She has been responsible for SCIR services at UMMC since 2006. And this year, Prof. Julia is the program coordinator of a Master's of Health Research Ethics, MOHRE. So this master's degree is a joint collaboration between the Faculty of Medicine, New Himalaya, and also Johns Hopkins Berman Institute of Bioethics, with the support of U.S. National Institute of Health, Fogarty International Center. And Prof. Julia is also the head of research, integrity, and ethics unit. So without further ado, Prof. Julia, the spotlight is yours.
All right, thank you, Sharifa, for the kind introduction, right? And thank you to the Research E-Carnival Committee for having me here. Let me share my screen first. All right, so is everything okay? Is in slide mode? Slideshow mode?
Yes, it is. All right. Perfect.
Okay, thank you. So I'm going to talk about patient and public involvement in research. What are the ethical challenges and consideration? Right, so, I'm going to talk about this, basically about these 4 things, right? This is the outline of my lecture. So I start a little bit on foundation of ethical research, and then look at PPI from the research ethics perspective, and research governance on PPI, and also, right, not related to research ethics, but still ethics, the ethics of working relationship with regards to PPI. All right, so for me, patient and public involvement in research there are 3 spectrum to it, 3 different areas that public and patient can be involved. One is as part of the research team, that is our main focus today, and something that is rather new. Next one is involvement in research ethics committee. I think this is not something new. We know that at least in UMMC, we have people from the committee or layperson as part of the reviewer of the research ethics application. And also, public and patient can be part of a research grant panel. I'm not sure about in UM, but we know that in overseas, they are part of those who determine who gets the research grant or not. Right, just to recap, this is the only slide on PPI, right? Just in case you all miss Prof. Liu's presentation in the morning. PPI can be defined as involvement of patient, carers, or the public as active partners in the design, delivery, and dissemination of research to ensure that it is relevant and useful. So the key word here is active partners. They are involved not just as an advisory, but in many activities in research. And this is also the next phrase is also mentioned by Prof. Liu in the morning, is research being carried out with or by members of the public rather than to, about, or for them. All right, so just go. I have only a few slides, 3 or 4 slides on principle of research ethics. So this is the 3 main principle of research ethics that was first published by the Berman Report 1979. It's about beneficence, respect for person, and justice, right? So when we say about beneficence, it's about the research should do no harm and it should maximize the benefit and minimize the risk. Respect for person is about respecting the person for being an autonomous being and he or she is able to make her own decision whether to participate or not participate in research. And for those who are unable to have that capacity to make decision, there should be some safeguarding measures to protect them. And justice is all about the concept of fairness, right? Fair recruitment of participants and about who bears the risk and who benefit from the research. In this book, on the Oxford textbook of clinical research ethics, the Emmanuel and his colleague, right, also listed 8 criteria or domains for requirement for ethical research. So you can see that there is social value, scientific validity, fair subject selection, favorable risk-benefit ratio, independent review, informed consent, respect for enrolled subject, as well as collaborative partnership. Collaborative partnership is in bracket because sometimes it may be necessary, sometimes it may not be necessary. But what I want to emphasize here is that we used to think that the research is ethical or not ethical. It's about whether we do any harm to the participant. I think that was what we used to think. But look at the scientific validity. So when we are talking about ethical research, it's about whether you use the method that you use, right? Is it scientifically valid or not? This is important because in my lecture later on, I'm going to talk about research design, just in case somebody wonder why do I talk about as if this is proposal reviewer rather than ethic research review, because we do need to make sure that the science is valid so that it can maximize the benefit to the intended society or community or individual. And a group of bioethicists from Johns Hopkins Berman Institute of Bioethics create a framework on how to analyze a case to detect whether there's any ethical issue in a particular case or research. So it is the combination of both the first 3 principles with the previous 8 domain that I mentioned that was listed in this the textbook of clinical research ethics, right? And they add up the integrity domain here. So what I'm going to do next is that I'm trying to see, will PPI, right? Will it enhance or will it compromise the elements or the criteria for an ethical research? From there, we can detect whether there's any ethical issue with PPI. All right, just to share with you, PPI is rather new, all right? So a lot of areas with regards to research ethics is still very gray. So this is a very recent study in 2021 on about PPI, and a section of the study actually asked 8 research ethics committee from 8 different institutes about PPI. And you can see that right from this one, would you say that your ethics committee is familiar with the concept of PPI? And only 2 said yes, and the others said no. And you can see here that in the last two column or rows of the table, right? Only 2, right? Approved. Only 4 of them have ever received anything about PPI, right? So there are eight research ethics committees. 4 have received, 4 have not received. So it is something quite new and a lots of gray area with regards to research. ethics, research ethics. So just to recap back, so I'm going to look into all these elements and see whether PPI enhance or compromise these elements. And not all of these elements are applicable. So I'm not going to go through all of these elements. All right, so if you listen to Prof. Liu lecture this morning, she did mention about social values, right? So social values can be seen as values shared by a community of individuals. They are values held by society and are contrasted with individual, right? Non-shared values. So this is the value of a community or society. The social value for society of intervention lies in the nature and magnitude of the improvement of the intervention expected to have on the well-being of patient, individuals in the society or society. So it's very important that the research that you propose, right, must have social value. And who determines the social value? Right, so in the textbook, for each of the domains, there are specific questions that to guide reviewer or researcher on how to evaluate a research proposal or a case on to determine or to detect any ethical issue in a proposal. So the question that is listed under social values were: who will benefit from the conduct on result of research? What is the potential value for each prospective beneficiaries? How will the social value of the research be enhanced? And how can adverse impact, if any, of conducting the research be minimized? I think it is quite clear from here that PPI has the potential, have the role to enhance social value, and this subsequently lead to a more ethical conduct of research, because the topic of research that they conduct, the PPI is able to, the participant of public is able to determine what is important in their society. For example, this is an example of how our involvement of PPI is able to determine what is important for them. So this is in Australia, yeah. So members of stable and neonatal death support Queensland identify growing need for support among women who have experienced miscarriage. So from their communication with their members, they realized that there was high level of variation in terms of quality of care received by women following miscarriage. So they want to improve that. So that was their priority. So because of that, they wanted to look at this more closely, and therefore work with researchers at the University of Queensland to design a study. So if the research topic comes from patient and public, and this is what they have identified as important, so there is high social value of this particular research. So this means that PPI will enhance a more ethical conduct of research. What about scientific validity? Right? The question that is under scientific validity would be: do the scientific and statistical design and method certify general accepted standard and achieve the objective of the study? If not, is there clear justification for the deviation? Will the research result be interpretable and useful in the context of the health problem? Does the study design ensure participants of healthcare services they're entitled to? If not, are there methodological compelling reason, and are participants protected from serious harm? Is the research design practically feasible given the social, political, economic, and cultural environment? If you look into PPI, do you think they're able to enhance the quality of the ethics concern of research here? And there has been a lot of reported issue in the literature about RCT. As you all know, when you study the effectiveness of a drug, RCT is the gold standard, right? You have to do randomized controlled trial. Otherwise, your people will not trust your study very much. So this is the gold standard. But right, when this is being exposed to public, and and patient, there is some conflict about RCT, because for them, this was something in about HIV and AIDS. Is probably at that point of time, there was no effective treatment. So the other arm will receive placebo. So RC study design is considered inhumane because you're giving some fake pill instead of giving them the potential effective treatment. And also at that point of time, they were refrained from taking other medication, including medication for symptomatic relief. There's nothing to do with cure HIV, but to relieve symptom. But because I suppose one, the outcome is, how well the symptom is controlled, they are not allowed to take other medication. And they're excluded from study because of past medication. So there's a lot of conflict here, right? Because they don't agree with the study design, but they have to, the researcher and the public or patient representative have to decide where is the middle point, right? And at the end of it, there's some they did not do RCT, so that is when when the scientific validity is being compromised. And this also occur in the use of hormone replacement therapy in breast cancer patient, where it is expected the other arm is placebo, but with the patient collaboration, they do not want the placebo arm, right? They want to be informed about different type of HRT so that they can choose which one they want. And they want prompt access to breast cancer specialist and gynecologist as required. And you can see that this is, at the end of the day, this is the RCT, where there is a HRT arm or no HRT arm instead of placebo, right? So this is how patient involvement changed the direction of study design, and when the change of study design can actually compromise their scientific validity. So in this instance, it does not enhance, but it compromises, right? And another thing about scientific validity is that ensuring the question is asked in a way that might provide an answer relevant to consumers. Quite often you see that when you see the research result, right, they are in outcome that mean nothing, does not mean much to the patient. For example, in this to improve research proposal improve mobility of people with knee problem, the one they measure is ability to walk for a certain distance. That is quite a common clinical outcome measure that we use. But for patient, that outcome is not important. They want outcome that is focused on function, which is like the regaining ability to drive, to climb upstairs, and so on. Because if you choose the wrong outcome, you can't really meet the beneficial part, because the outcome you choose does not really mean much to the people. So with PPI, right, the clinical outcome would be the outcome that you measure is the one that is important, and because of that, it is transferable or something that can be used to benefit them, rather than something that, for example, the strength of improve from 2 to 3 might not mean anything to them. Next, about informed consent. I think this is something that is very familiar to all of you, right? Whether and it start with whether the recruitment procedure incentive consistent with culture, political, and social practices of potential participants in the community. Disclosure form and verbal disclosure procedure sensitive to patients' culture, language, and context. And important, is the information presented to participants complete, accurate, and not overwhelming? Are there appropriate plan in place, right, for obtaining permission for legally authorized representative for individual unable to consent for themselves? And how will individual participants be made aware of their right to refuse to participate? Just for your information, a lot of ethic application actually get returned back, revised, need to be revised, mainly because the informed consent are not something that can be understood by lay person. Because you just remember, your participant need to make sure that they really understand what's being written in informed consent to enable them to make an informed decision to participate or not participate. So how does PPI relate to this? Right? And starting from the recruitment procedure, right? Because informed consent start from recruitment procedure. So this is an insight study, right? Investigation into stillbirth to inform and guide healthcare staff training, right? So what they realize is that they need to improve service or the service they give to those who just have stillbirth, but they're unsure how to approach the patient, how to the design of the study. So with PPI, right? So they have public and patient expert there. So they're able to design a study, and this patient actually attended the ethical interview along with two researchers, and she explained during the interview that what is the best approach to potential participant. Like when it is best to approach before they leave hospital, give them a bit of information, and then an invitation to receive further detail if they're interested to participate in the study. As you all know, this is a very sensitive issue, and if you do it the wrong way, it can cause trauma to them. So there is an ethical concern on what is the correct way. So because of PPI, the committee was satisfied with the proposed study and was acceptable to a bereaved parent. So, and able to answer in that question at the interview that the clinician possibly could not answer. There are things that you do need the PPI to make sure that your research is conducted in an ethical manner. Right, PPI informed consent document. PPI actually can help, can make sure that the information sheet about the research conform to the style and the content useful for potential participant. Community members are in the position to know what prospective participants should understand before deciding whether to enroll in the study. Right? A lot of patient information sheet actually in medical jargon, and it's not very, and sometimes just because the patient sign, we think that, right, patient understand it, but not necessary. So, and sometimes it's because they feel adapted to you, that they respect you, so they sign. So it is important that this information, informed consent document can be understood, and PPI actually are in a better position to know how to write, what to write in the document. However, as this is new, there are, of course, argument to this. So there was a study, right, by Guarino et al. So what happened is that they developed an informed consent by the researcher, and then they presented it to the service user to adjust. That's the PPI, right? But what they found is that there was no significant difference in participant understanding of the study reported between the two consent documents. So it raised another ethical issue. Is it ethical to spend money? Because when you have PPI, it's not without cost. It's money, time, and also manpower. Is it ethical to spend on something on PPI when it does not make a difference, right? But what they found out is that, the right way is that you ask them to write and not to check on what you have written. So that will make a difference. So a lot of information on how to implement PPI is not clear. So from this study, they conclude that it is because the way it is done that make it, not because of that, there's no difference in the consent form. Right, so this is another example on how PPI help in with regards to the informed consent. So this group of researchers want to do a study on routine oxygen supplementation after acute stroke, and consent needed to be done within 24 hours of stroke, of which most of patients are actually not able to give informed consent. So they have three focus group discussion with the carers and with patients who had previous stroke. So the question they asked them is that, should they be included or should they be excluded? And who should give the consent? Through the series of discussion, stroke patients believe that this patient should be included, and the best person for LAR, which is legally authorized representative to give consent, would be their relative or their spouses. So in a way, it helps in terms of, it gives some information or some guidance to the researcher on how to get informed consent with regards to this study, right? So, and this is also a study on PPI activity in the PRIDE study, right? So they involve the patient and public in 4 stages of research activities, has a co-applicant of a grant, has an advisory group, has an actual co-researcher in data collection, and also has a co-researcher for data analysis. So I'm just going to concentrate here because this is a good example on some ethical issue when they are involved with data collection. So this is about dementia, and this data collection is on interview with caregiver on the experience of dementia. So the co-researcher, which is the carer, perform interview with people and carer with dementia. So there is a problem there because there is a conflict in roles experienced by the co-researcher, right? Carer co-researcher reported at times they wanted to step away from the constraint of the interview role and offer advice to people they were interviewing because there is disconnection, and the time that is they're unable to remain neutral when they hear the story that is very close to them, right? And they struggle to balance being a objective researcher stance with experience of empathy as a fellow carer. So this, the reason why this can raise ethical issue is that as researcher, you must maintain being neutral, right? And when you are unable to maintain being neutral, you can influence the result of the study. That's one thing. Second thing is that when you come up for your researcher role, right, during the research process and give advice, there is this whether you are competent to give advice is one of the issue, right, during that interview process. So there is an issue of professional competence that can lead to ethical issue during research when they become co-researcher, especially when they are in contact with participants. Confidentiality, and we all are very, as researcher, we are all very well versed with confidentiality. But in this issue, it is about 2 types of confidentiality. One is co-researcher information, because these are patients, right? They're actually patients, so they have their own history, and also whether they're able to, they must be able to protect patient confidential information. So as a co-researcher, right, sometimes when in meetings, right, they might discuss their own treatment and care during researcher meeting, which can raise a range of ethical issue, because those are whether those are confidential, those are their personal information, and that at that point of time, the relationship is researchers. They are not patient-doctor relationship anymore. So whether that can sometimes give a researcher an uncomfortable feeling, right? And then co-researcher might, the patient or public representative might not be certain on what to expose about themselves during the meeting, because this is not patient-doctor relationship anymore. So it can be an issue right here. And the next one is, of course, whether they should be given access to information, research information like any of us. And the consensus is you should make every effort to make sure that he or she has equal rights to rights like other members to have access to information of the research information, right? And in some like in research grant and in research ethics, they actually sign a confidentiality agreement, so they can do the same here to make sure that whatever information that they gain that they know about the research, they should not leak it outside the research circle. What about research governance on PPI? Prof. Liu mentioned just now in Malaysia, there is no PPI mentioned in any of our research document in Malaysia, right? So I found that of course, UK is very strong when it comes to PPI. So there is this involved document, which has quite a comprehensive guidance on how to go about PPI. There's another one will be the Australian. They have a framework for PPI as well. Right. So there is always a question, do I need to ask for ethics, right? When I involve patient in designing, right? Designing, for example, you are applying for grants, so have patient with you to help to work together to apply for this grant. Do I need research ethic committees? It is not needed, right? This is UK, right? And also if let's say there is personal data information involved, right, that is protected by the Data Protection Act, right, it needs to be approved. You need to apply for ethics committee, just like any other secondary data analysis. And the next one is that if they're involved in the actual research where there is direct contact with study participants, there is a special ethical consideration approval, right? So because the well-being and safety of people who are actually involved as researchers need to be cared for, right? Because they may find, especially in qualitative study, talking to other people reminds them of their own negative experiences. So what research ethics want to make sure that they have enough training on this, because that leads to competence. And the well-being and safety of people who are taking part in research as study participants as well, right? Because we don't know, maybe because of the very close experience, but the co-researcher might lose control and so on. So it's important that there is no additional risk to people taking part in the study. So in the UK, if there is contact, if the co-research, if the PPI, there is a contact with research participant, there is a special consideration. All right, so the Pride study mentioned that when they inform in the ethics submission that they are working with people with dementia, the co-researcher, the ethics review body required researcher to be informed and protected in the same way as research participant, where they need to provide with tailored information and consent form as well. We are done with research ethics, so now we're into ethics. You know, what are good ethics working relationship with the public? And this is also written in regards to the NHS as well by Pandya Wood et al. So they listed actually 10 areas of ethic consideration when working with the public. This is not research ethic, but working ethics. All right. So the first one mentioned here is allocating sufficient time, right? Based on the ethical principle of respect. It is quite I would say quite common for us to give things last minute, right? For example, this is by the researcher, can you ask 2 people in your group to read this by tomorrow? I am submitting the bid the next day, right? So you should allocate sufficient time for the lay person to read through the document that you gave them, right? If you don't give them enough time, they are unlikely to be able to contribute meaningfully, right? And then they are not truly engaged, right? So the principle of PPI is being violated, right? So, and you must remember that a researcher must remember that some of the document some of them might not be very familiar with the document. So you must give them time to enable them to really be involved in this research activity. Second thing is avoiding tokenism. This is also something that was mentioned in the morning lecture. It's not about just ticking the box. It's more than that, right? And sometimes it's just to meet the criteria. So the patient group didn't really get what we are doing. So I haven't included the suggestion in the bid. And the researcher proposed that maybe in the future, they would like researcher to actually write, how exactly the research design with public involvement has occurred and what difference it made to the proposal. This is because this is with NHS, so registering of research design stage public to design to stage public involvement work early with NHS, right? So a lot of people think that I do not need the R&D office of my public involvement activity until research gets funded, right? Because involve is part of NHS initiative, I assume that there are some funding and support when a researcher involve public in their study design. So you can see here that this is written there, right? So R&D officers should afford the researcher with practical and administrative support around local governance arrangement. And communicating clearly from the outset. So this is the voice of the public contributor. I was pleased to be involved early on, but I really did not understand what I was being asked to do. Not enough effort was made to explain things to me. I felt left out of the discussion, right? And the public involved at research design requires some information, the same information like the rest of the team, but you might need to communicate it in ways they can access and understand, right? And do not take them for granted. They are there. You have ticked the box and leave everything else, And this one as well, it is related to the last one. You can see a member of the public saying to a research colleague, I have agreed to help design a study, but I really feel overwhelmed by the amount of things they are asking me to do. I honestly have not got any more time and do not want to continue, but I feel like I have to help because I said I would. Initially, they said it would be one meeting, and so far I have 4 2-hour-long meetings with them. So it is important that the public know that they can stop the involvement at any time without detailing the reason for doing so. Just like how research participants can withdraw themselves from your research. So they must be made known that if they feel that they do not want to participate anymore, it is okay for them to stop, right? The next one is the fairness of opportunity, right? You have to make sure that you include the relevant PPI, the relevant public or patient in your study. For example, for this researcher, my study is about young Black and minority ethnic children. but I can't find any. And he just bring whoever that, other children, right? So it's not fair, because the particular children or particular community must be involved. Otherwise it doesn't have any meaning, right? So it's important that the background of the research subject and the background of the public or patient were involved has the co-researcher make sure that it match. Otherwise, it would not have any meaning to do PPI. This is very true. Differentiating between public involvement and qualitative research methods. There is blurring of boundaries between public involvement and qualitative research. A lot of the studies that I gave you, the example just now, a lot of them actually detailing PPI, but the public and patient actually are participant in a research. So a lot of them are treated as focus groups with all this transcribing and research data being published, right? And there is a difference between, let's say, we do a meeting with the public and patient, and we talk and discuss, and we have a meeting minutes, and that's it. And actually a focus group discussion where it is recorded and is transcribed and is published. So there's this blur line between those two. And that's when there are confusion whether do I need to ask for research ethics before I start working with the patient. Because sometimes when they work with the patient, they are working in the context of qualitative research rather than working in the context of researcher steering group meeting, right? So a lot of literature actually on this experience on how they have PPI to design their study. A lot actually part of a qualitative research where the public and patient are research participant rather than co-researcher. Right? Should the one is valuing, acknowledging, and rewarding public involvement, right? Do you pay them? How do you acknowledge them? It is important to acknowledge their involvement through reward and recognition. But some patients prefer to volunteer, others prefer cash payment or vouchers. And consider patients are less financially secure, because when you do PPI, you need them to spend time with you. You need them to come. Things like childcare, things like missing time from work. You need to consider those aspects, right? So it's not ethical for you to assume that they have the time and commitment as you are, and not reward them in any way that they would like to be rewarded. It is easy for post-funding, because in your research grant, you can actually ask some honorarium or incentive of payment for co-researcher. But pre-funding is actually quite tiring as well, a lot of commitment. Who's going to pay for the pre-funding? So I think that's when in NHS, they have this fund to help before the grant is being awarded. But for us, probably we have to think about how else can we reward them. So in conclusion, this is my conclusion, right? PPI will lead to more ethical research, because I believe that it makes the research more meaningful. Definitely there are challenges, right? But I believe that it can be overcome with education and training. These are some of my references, and thank you very much. This is not an easy topic to talk about, but I hope all of you get something, learn something, like how I learned when I prepared the lecture. Over to you, Sharifah.
Thank you so much, Prof. Julia, for sharing your insight on PPI on ethical issues regarding PPI. We do have several questions from the audience. So let's go on first on okay. So the first question is what is the main criteria we should look at when selected for patients to be included in our PPI element of research? So what are the criteria that we should look at?
Well, like Prof. Sume said, who is this population that you want to research on? If of course the population have to be that population relevant. Criteria, I can't really, I think this is Prof. Sume's area, and maybe later on Professor, the next plenary speaker will explain to you, because my experience with PPI is mainly in my community research, right? So of course I chose those who I work with from the right population. I can't really answer your question because I don't really have much experience in selecting the beside the people, beside that they must be from that particular group they're interested to research on.
I see. Okay. There's another question from the audience. And the question is, how do you all choose the public to be panelists in the medical ethics review board?
I am the external reviewer for rehabilitation. So but then I am the expert panel. Yeah. So for example, you have patient advocates group, right? You also have people who really from the community that volunteers to sit down in the research ethic committees, and they receive training. Yeah, and that's about it. I mean, there is a training.
Okay.
Yeah.
Following up on that, so does the training include PPI?
No, PPI has not. There is no documentation of PPI in research in Malaysia right now, because it's something new. The only training you have is like Prof. Liu said that they're starting one. Yeah, but PPI is rather new. Yeah, a lot of involvement are not actual PPI, even though we have stakeholder engagement, that they don't take part in the design of research.
Okay, noted on that. So this is actually quite a burning question, Professor. In the third world countries, PPI is successful due to tokenism. So if this aspect is taken out, what would happen to PPI and how do you mitigate this problem?
A lot of, it is true that a lot of criteria in research grant, they put PPI but it's not really PPI. Like in our research grant is that who are the society that will work with you? And we said, for example, Spinal Cord Injury Society, but that does not entail PPI. So there is no real PPI requirement in our research grant, but they has one of our stakeholder, but they don't design the research with us. Yeah, they don't design. But if PPI is taken out, researcher will do research that might not meet the needs of the people that you research on. So it's very, very researcher-centric rather than patient-centric research.
Thank you so much, Professor Julia, for your input and explanation on the ethical conundrum surrounding PPI. So let us just quickly check if there's any other questions from the participants in YouTube. No, I think that's it. Hold on. Okay. So thank you again, Professor Julia, for sharing with us. So before we continue on to the next event, it's just a few housekeeping announcement. Is that for those participants who recently joined us, please register so that you can be included in the raffle in the lucky draw, and that's the first announcement. And the second announcement is that please make use of the Q&A session instead of the comment sessions to ask questions to our panelists, to our speakers. Our next big event for the evening is the International Plenary Speaker session by Professor Sir Terence Stephenson. So Professor Stephenson is a Nuffield Professor of Child Health at the Great Ormond Street Institute of Child Health, UCL, and he is also a co-director of the National Funded Children Policy Research Unit. So Professor Stephenson has recently been a knight in 2018 New Year honors for his service to the healthcare and children's health services. So as a researcher, he has received over 13 million in funding throughout 46 different awarded grants. And currently, Professor Stephenson is the chair of the Health Research Authority under NHS, which this body approved all research undertaken on patients in England. And in 2020, HRA have approved 700 fast-track research studies involving 600,000 members of the public. And bear in mind, this is during the pandemic. So what an admirable number. And we hope to learn more than a thing or two from you, Professor. So audience, please take this opportunity and ask questions in the Q&A tab. And also, if you're watching us live on YouTube, please comment, do ask questions on the comment sessions. So with this, I extended my warm welcome to Professor Sir Terence Stephenson to deliver his talk on patient and public involvement in research. Professor?
Thank you very much. Can I just check? Can I check that you can both see and hear me clearly?
Clearly, perfect.
Wonderful. I listened into the previous talk. I must say it was a fantastic talk, and in some ways has stolen my thunder. But they say in teaching or lecturing, repetition is always a good thing. So you'll hear some of the messages you've already heard repeated. I'm going to share my screen with you, and I just want you to let me know that you can actually. Let's just check that you can. Okay. Or
Sorry, Prof, we kind of lost you just now.
yeah, I'm not. Have you enabled me to screen share?
Oh, no, you are actually our panelist, so you have full access.
I have full access because at the moment it's not letting me share the screen.
Oh, it's not letting you share the screen? Okay, hold on, we'll get our IT team to get into it.
Let me see if it's something at my end that's stopping.
So Professor, just give us a minute. We'll try to get you the full access. All right, we have been informed by the IT team that you are on full access for the Zoom webinar.
Okay, I'm going to quit and rejoin you and check. Okay,
Brilliant.
I'll be back.
Okay, let's do that. Sorry, everyone, for the technical error. So it is inevitable. It happens in every online session. Just give us a few minutes while Professor Stephenson's joining us back.
Okay, can you hear me, Sharifa?
Yes, we can hear you clearly.
Okay, it says you cannot start screen sharing while the other person screens. That seems to be the problem.
All right.
So maybe because you've
we're
got.
trying to stop share at the moment. Okay, it's all you now.
Let's try
Perfect.
that. Okay, I think
Okay.
this is okay. Can you see that?
Yes.
Can you see
Perfect.
my?
Yes, clearly.
Okay. Oh, I think that was the problem. Anyway, you can see and hear me clearly.
Yes, exactly.
Wonderful. Well, thank you so much for inviting me to speak to this important conference. PPI research has become a very important thing in the last, I suppose, over the last decade in the United Kingdom. If I use the word UK, that refers to the United Kingdom of England, Scotland, Northern Ireland, and Wales, although I only chair the Health Research Authority for England. Okay, so Richard Horton, who is still editor of The Lancet, what we need is not more research, better research. Probably your experience, like we're all with publications and papers, far too many. And yet, despite him saying that, you'll all be familiar, I guess, with the fraudulent study by Andrew Wakefield, claiming a link between MMR, measles, mumps, rubella vaccine, and autism. That was published in The Lancet. And I put it to you, maybe by the end of my talk, you'll feel that involving patients in the public might have produced better research and might have avoided this research fraud early on. So this is what I'm going to talk to you about. I'm going to talk for about 40 minutes. That's what I've been told. And then we're going to have 20 minutes for Q&A. But if the technology allows us, I'm going to try and pause a few times to ask the participants to be involved. So listen up, because I'm going to be asking some questions. Not questions where there are right answers, just to try and involve the audience. So I'll tell you what the Health Research does, why PPI is important. PPI was set up. You can probably hear an ambulance in the background. I'm sorry, I'm at the hospital, it's busy. What we learned from the COVID pandemic, which was mentioned in the introduction, and then taking forward what about the future, making the involvement of patients in the public the absolutely normal practice, not something that's exceptional. So what does the Health Research Authority do? This is our 10th year birthday. We were set up by Act of Parliament in England in 2011 to try and promote research, help research happen, but at the same time, we've got to protect the patients and the public from fraudulent research, from unethical research, from research that's of no value. So two things: protect and promote. And so we review the ethics and approve that you cannot do research on patients or on healthy human volunteers if it was invasive, if it involved blood tests or endoscopies in volunteers. You can't do any of that unless the Health Research Authority allows you to. And the idea is to make it easier to do high quality research. And we've come to realize that involving patients in the public actually doesn't get in the way of research. It makes it more likely that you'll do good research. We have 65 what we call RECs, Research Ethics Committees. You may hear me use the word REC, or you may see REC on my slides, across England. We have 845 members. They are volunteers. They are about half lay people, members of the public, and half of them are doctors, nurses, scientists, researchers, statisticians, ethicists, philosophers, all sorts of people from a specialist expert background, but half of them are just lay people, some of whom who have been patients and some not. And we deal with, on an average year, we deal with over 5,000 applications a year, pre-COVID. And then, as was said in the introduction, during COVID, we've had a separate 700 research applications about COVID, just about COVID. And what do I mean, apart from ethics, what do I mean give approvals? Well, research doesn't just involve ethical dilemmas, which the previous speaker spoke about, but research can involve giving radioactive substances to volunteers or patients that they wouldn't otherwise have. It may involve, so that's the first one. The second one, it may involve exploring their data by people who aren't looking after them. So they don't, if you're not careful, it's a breach of their confidentiality, their own medical personal data. So we have a confidential advisory group advise on that. Gene therapy is something that cannot be done first in humans. When done first in humans, it can only be done on patients. Traditionally, research starts in the lab, then perhaps you use mice, animal studies, then perhaps you use young, healthy human volunteers, then a phase 1 study. Gene therapy, you can't interfere with the genome of healthy people, so you have to start with people who already got severe disease. So that's another kind of approval. Giving new drugs, classic randomized controlled trial, a new beta blocker versus an established beta blocker, that would require an involvement of another agency, the MHRA. And then vulnerable groups, the example I give is research has to be done on people in prisons to help make their care better and their health better, but they're very vulnerable. So you have to be very careful about people doing research, for example, on prisoners, or as you'll see later, people without mental capacity or dementia or Huntington's disease or severe disabilities or psychiatric illness. They're all vulnerable people who need to be protected. Well, in the United Kingdom, fortunately, the general public attitude towards research is very positive. In a survey, we did 83% of people say that health research is very important. And the pandemic shows, as you heard, actually updated since I sent in my biography, I think over 1 million members of the public, either volunteer citizens for vaccine trials or patients in hospital, have been enrolled in those 700 studies that we mentioned. So the pandemic has actually raised the profile, the importance of research, the recovery trials showing the importance of dexamethasone, trials showing the importance of not using positive pressure ventilation if you can manage to do it with, say, CPAP, the importance of vaccines. And I think the public now are more aware than ever of the importance of research. But to maintain that trust and to maintain that 8 out of 10 people say research is important, we've got to take them with us. And that is why PPI is so important. People don't want, they're happy to have research done on them. They don't want research done to them. They have to be involved in the decision making. And I mentioned we get 5,000 applications a year. The commonest single reason for the Research Ethics Committee to decline a research application is it can be declined because it's poor quality research, or it's badly thought through, or it's underpowered, or the statistics are weak, or it's dangerous. But actually the most common reason is that the consent form that people have to read and sign, written informed consent, and the public information sheet that tells what the study's about are of such poor quality. And as you'll see, those are two things where PPI can help enormously, because doctors and researchers live and breathe their research, understand all the jargon, they're very au fait with all the terms, and they find it hard to put themselves in the position of a patient lying in a bed in hospital or an intensive care unit being approached by a complete stranger who effectively says, in this research, we're going to toss a coin. And depending on which way the coin comes up, if it's heads, you're going to get this drug. And if it's tails, you're going to get this drug. Now, that's quite a challenging situation. And it needs good information sheets and good consent forms. And researchers in the UK get that wrong a lot. And I think PPI would help. PPI, as I think the previous speaker mentioned, it's not a legal requirement for research, but we expect it and we advise it. So if you don't want to do any PPI, you come before a Research Ethics Committee, expect to be asked to explain why you did not involve the public and patient. And if your answer is, couldn't be bothered, didn't think about it, didn't know, no time, the application will be rejected. There would have to be some very powerful reason why you could not involve patients or public. And I repeat here in bold, it will help the researchers in advance of appearing before the Research Ethics Committee. It will help you have a good research proposal that will be successful, because the commonest reason for the Research Ethics Committee to reject your proposal are problems with the patient information sheet or the patient consent form. Now, there's nothing new about this. I'm a practicing doctor. When I first started practicing, I qualified as a doctor in 1983. I don't think we involved patients very much in designing our hospital service, our clinics, our outpatients, our wards, how we did our ward rounds. But we've come to realize that by involving patients, we get a better service. It's not rocket science. TripAdvisor. Why do hotels read TripAdvisor? They want to make a better service for their customers. The best way to do that is to ask your customers. Hotel managers probably think they know best how to run a hotel. Doctors and nurses probably think they know best how to run a hospital. But actually, if you don't ask the people using it, the end users, it won't be good. So these are a few slides from the Academy of Medical Royal Colleges, which I chaired before I chaired the Health Research Authority. So this isn't about research, this is about running a clinical service. And about 10 years ago, one of our leading politicians coined this phrase, that the phrase would be nothing about us without us. You have to involve us and take us with us. In designing the health service for the people of England, patients should be involved in decisions about their own care. So that's shared decision making. That's me as a doctor, involved in the care and hospitals and so on.
Professor?
I can hear you.
All right, sorry, you got cut off for a good 20 seconds just now.
Oh, I'm sorry. I think maybe the Wi-Fi is a little unstable.
Yeah, it keeps popping up on our screen as well.
Yeah.
The internet is unstable, but yeah, go on. Sorry to cut you.
Okay. Well, please do feel free to interrupt me if I drop out again. I'm happy to go back. Okay. Absolutely. Happy to. You know, it's important you interrupt and say, look, we can't hear you. Okay. The idea is to ensure that services are designed with patients helping us. Okay. So these are the benefits. Better for the patients, actually better for the doctors and nurses because they know what the patients want. Because we don't ask patients enough about their experience of taking medicines, how they're going to take them, who's going to give them to them, and so on. And this advice on how to set up a health service would apply to research, how to involve them. Involve them from the start, not at the end. It's just like statisticians. You don't give them your research study at the end and say, how do I do the statistics? Listen to your patients. Not only the researchers, the doctors, the nurses, the statisticians, they're not the only people with evidence. Patients from experience, so-called experts by experience, they have lots of evidence. Cultures we have. You have Malays, you have Chinese, you have Indians, you have men, you have women. We have a very multicultural society too. And it's important that you involve everybody and people with disabilities, obviously, of course, as well. So I'm going to give my 3 examples and I'm hoping, let me see if I can see, I'm screen sharing. Let me see if I can, when I'm screen sharing, I can't see whether any, I'd like to ask you whether anyone would like to suggest in this study here, a trial piece of research to work with people who have dementia. Does anybody like to suggest what might be the benefit of involving patients in public right at the beginning? But Sharif, I don't know if this is going to work. If can you see people with hands up or?
Unfortunately, because this is a Zoom webinar, so our
I
attendees can
understand.
is a one-way
I
communication.
understand. Absolutely no problem. So
But you
because
know
I think
what?
it's going.
I am going to encourage them to type. So attendees, you can always communicate with us and with Professor Stephenson from on the chat.
Okay. And you can let me know, Sharif, I can't see the chat while I've got my slides up. So if you
Yes.
see some people asking questions or making comments, please let me know what they are.
Definitely will do.
Oh, I think this is, because this is being live streamed, I won't try and make it interactive, and because the internet's a little unstable, this was a study. I wanted to look at playing music for people with dementia. Now that's not a new concept, but it's not been well researched. But many carers have said, my father has dementia. I found that by playing music to a music that he's familiar with, it settled him. So they wanted to look at the range of responses to music and determine which music, classical music, pop music, ethnic music, what give the most positive emotional reaction. Now, the Research Ethics Committee was concerned about the fact that people with dementia might lack capacity to give consent, mental capacity. So there was quite a lot of work needed to be done with the public to make sure that the information sheet was good and the informed consent was good. But eventually, the Research Ethics Committee said, yes, you can do this research, but let's start with adults who have mild dementia, who have capacity to consent. Let's see how that goes. And then we might consider extending the study to those who don't have capacity. So that was in 2019, that study was put forward, and in October 2019, it was approved. By March 2020, we had the pandemic and recruitment to the study stopped because everybody was devoting themselves to managing sick people with COVID. But in August 2020, as we control pandemic and numbers, researchers forward an amendment to then expand the study to include our thinking capacity, propose a new music soothing or whether the carers thought it was helpful, but also to look at if the brain lit up while they were listening to the music. So my second example is a current study to investigate. There's been a lot of debate about what's the best optimal gap between the first COVID vaccine and a booster. And pregnant women are one of those groups, like children, like people with dementia, like disabled people, where often research is not done because people are worried about causing harm. So there are potentially huge benefits of involving pregnant women in the design of this study. It's very important to get recruitment. It's a study that will look at this matter, and pregnant women will receive either 2 doses 4 to 6 weeks apart or 2 doses 8 to 12 weeks apart. And by studying their antibody levels and how many of them catch COVID, we'll be able to decide what's the optimal booster. Now, this is a big study, but it's involving pregnant women, so there's a sensitivity. And they're going to be asked to attend 9 visits. They're going to be asked to keep an electronic diary. And in the PPI, they said, well, look, we're worried about our unborn baby. You need to give us a 24-hour mobile number so we can contact someone at any time, middle of the night, if we're worried about our pregnancy. And so that wasn't something the researchers had originally planned to do or got funding for, but through the input of PPI, and it also helped with designing the electronic diary, because the pregnant women were able to explain to the researchers the practicalities of filling out an electronic diary. Also, this trial obviously involves taking blood samples from the woman to look at their antibody levels, but they also want to take a blood sample from the newborn babies, see if the antibodies cross through the placenta. We can do that on cord blood or on newborn baby blood. And they want to take samples from breast milk as part of the safety study. And the hope of the researchers is they will get confidence of pregnant women when they put forward the best vaccine strategy. They're most likely to gain the confidence of pregnant women if they involve pregnant women in the design of the research, and if when they publish the research and when the newspapers reported, that they can say pregnant women were involved in the design of the research from the beginning. Last thing I want to go to this, to train anesthetists. I've had major surgery 4 years ago on my spine, and when you're in pain and discomfort and you're in a strange place and you don't have your family there and you're not in your own bed, sleep is a really important thing. And they wanted to see whether the use of earplugs and eye masks, what you might wear on an airplane, would improve the quality of sleep after colorectal surgery, a study done in Singapore. It's a very good study. I've read it, but it's impossible to work out whether the public and patients were involved in the study. Primary outcome was a sleep questionnaire, and the secondary. If I were doing this research, I would definitely want to involve my patients, previous patients with colorectal surgery, in designing those. Because, for example, for me, I don't have any trouble getting off to sleep, but I often wake up at 4 a.m. in the morning. Other people have real trouble getting off to sleep. Some people wake up and can't get back to sleep. I wake up, and if I play music in my earphones or I listen to an audiobook, I'll go back to sleep. So I think involving people, sleep is just a simple thing, and patient satisfaction. Somebody might want 8 hours sleep. Somebody else might be satisfied with 5. Somebody might want 5 hours good sleep rather than 10 hours of interrupted sleep. So it's very hard to work out that they ever involve patients in this study. And when you look at their consort chart, they approached almost 140 to be in the trial, and almost 25 declined to participate. Maybe they declined to participate because the research, where they said the researchers, well, have you involved any patients in designing the study? And they said, oh, no, we haven't. Or maybe they said, did you ask patients about this? You want me to fill in this questionnaire? Have patients been involved in the design of this and in the consent form and information sheet? And maybe the researcher said, no, I don't know, you can't work out. And then at the end of the paper, the trial, it's been published in one of the really big journals that anesthetists read. They say the trial has several limitations. They're very honest. So patient compliance, that was using the eye mask and the earplugs, was a problem. And they analyzed 2 interventions at once. Instead of, maybe they should have looked at earplugs in one group, eye masks in another, and maybe both in another. Maybe some people found wearing an eye mask and earplugs at the same time unpleasant, uncomfortable, too many things on. Maybe some would have liked just a mask. What's not clear, and in the study, they tell you which earplugs and which. So, for example, I used to wear earplugs bed with a wire going, and difficult to sleep. I find AirPods are better because you can lie on one side and put the AirPod in the other ear, and you don't get the wire going around your neck every time you turn over. So I don't know whether they asked any of these things or not. Okay, what did we learn from the pandemic? Well, we had a shock. The pandemic is the pandemic. People are dying. 250,000 people have been infected. 250 million have been affected worldwide. I think something like 8 million, 5 million people have died worldwide. People do research. We understood that. And to help them, we set up a fast-track approval process at the Health Research Authority. So pre-COVID, it would take about 2 to 3 weeks, the blue bit, to review the ethics. And we were allowed up to 60 days by Act of Parliament to give the full approval, looking at the other things I mentioned, radiation, confidentiality, data searches, all that. During the COVID, if we prioritized it, if the chief medical officer says this is a really important study, we were doing the ethics review sometimes within as little as 72 hours and giving complete approval within a week. So we were doing our bit to get on faster. But we still expected the patients and public to be involved. But we were hearing stories from the public that they weren't being asked to be involved in this research. They were getting very few requests from the researchers to help them design their studies. And when we surveyed this, we found at the beginning of the pandemic in March 2020, only about a fifth of researchers were involving patients in the public, whereas pre-pandemic, there's only a fifth who were not involving researchers, 4/5 were. And we were quite alarmed by that. We kind of understood, we were sympathetic. These people are trying to get on with the research quickly. We understand that. But we also think PPI will help make the research better, as the examples I've given you. So we asked the researchers why, and they said, look, we're working really fast to get on with these trials on intensive care. People are dying. And we just don't have time to involve the public. But actually, we thought we held a meeting in April with the public and with researchers, and we thought there was scope for making things better by doing a kind of speed dating, really, trying to bring the public together who might be interested in ventilator research or vaccine research with the researchers who were leading this. So what we did, we set up, we collaborated with 56 different groups representing the public, about 8,000 people, and we set up this matching service partners. So research teams could contact us and we would put them in touch with members of the public who had relevant experience, who maybe had been on intensive care, who maybe had had severe viral infections, who perhaps had been in previous vaccine trials, who could help them. They were all over England and in Wales, Scotland, and Northern Ireland, but I'm only responsible for England. They were very helpful. And what we would ask them, as the public, how many meeting we need to we need to know that what experience, what's your age, and I mentioned diversity. So we want to ask about ethnicity. We don't all want white people. We want a range of people. And we would ask the researchers in advance, you need to summarize your research in plain, simple English, no jargon, no scientific terms, because we're going to give it to the public in advance. What do you think you need from them? How many people do you need? What would be the relevant experience? And what's the deadline? Do you need answers from these people by tomorrow or by next week? Or will your study at the moment is at the lab stage, you won't need answers for 3 months. So, and this is the impact this had. I said to you pre-pandemic, 80% of researchers of those 5,000 applications we get per year, 80% would have PPI. At the beginning of the pandemic, it was back over 80%. So it can't, even in a pandemic, and
Professor Stephenson, hello.
yes, hello, can you hear me? I can
Yeah,
hear you.
we lost you at pandemic. That was the last word.
Okay.
Maybe you can repeat, the last 20 to 30 seconds. We did not get your point just now.
Okay, did you
We lost you for about 30 seconds. So the last word that it was on the pandemic.
Let's see. Did you get this here?
No.
Okay. Shall I start from here?
Yeah, from here would be good, please.
Okay. Okay. Approval. Take 60 days to give the full approval. In the pandemic, the Health Research Authority reduced that to about 72 hours for ethics approval and a week to say people could start the study. So we were moving very fast. But we were concerned that PPI was not happening, and the public were telling us that this research is happening very fast, but we're not being asked to input into it. And we did a survey that showed before the pandemic, 80% of researchers involved the public. But during the pandemic, at the beginning in 2020, only 20% were involving researchers. So what we did is we set up a meeting with researchers and the public to say what's the problem. And what they told us was that they're trying to work very fast and they find it difficult to get members of the public to help them. So we set up a speed dating or matching service where we got 56 groups of public to meet, 8,000 members of the public to meet with the researchers. And we tried to match members of the public who had been on intensive care or been in a vaccine study before or had a viral infection, match them with researchers who were interested in that area. And we had groups from all over the country help us, 8,000 people. And what we showed by asking the public, the researchers want to meet you, but you need to really show them there'll be enough of you, you've got experience, you've got a mixture of ages and a mixture of ethnicity. And we asked the researchers, summarize your research in plain English, keep it simple, tell us what kind of people you need, tell us what kind of experience you want, and tell them how quickly you need to be involved. And by doing that, by bringing them together, we were able to show that pre-pandemic, 80% of researchers involved the public. March 2020, during the pandemic, only 20%. By doing what we did, by matching researchers to the public, by August 2020, we were able to show that 80%, back to 80% of researchers involved in the public. So this is important, and the public expect it, and it is possible. Sharifa, were you able to hear that? That's the big message, that it can be done.
Yes, yes, it is clear.
Good. Okay. So we also asked the public to tell us about their experience of the pandemic. Why had these problems arisen? And they told us 4 things. Leaders need to be really clear about public involvement can be done, it is feasible. You need shared information, and you mentioned diversity several times. You need to give information that we want older people involved, younger people, Black people, white people, men, women. This costs money. It doesn't cost a lot of money, but you can't hold the kind of meetings I've been talking about without some resources. I think the pandemic has shown us, as we're having today, although I'm sorry we're having some problems with our Wi-Fi, but we don't all have to travel and meet in person. You can do quite a lot of this virtually with Zoom or Teams. And there needs a real clear steer from the leaders of research and the leaders of the health service that they expect researchers to involve the public and involve every step. So I said at the beginning, like statisticians, you don't design your study and then go and say to the public, we want your help. In my own, I'm co-director of a research unit, as I mentioned in my introduction. For every study, we ask young people and their parents, this is what we're thinking of doing. Do you think we've got the right ideas? Is this an important subject? Are these the outcome measures you think are interesting? Are they relevant? Is the study design going to be acceptable? So I'll give you an example. I'm leading a big study on long COVID in teenagers, the biggest study in the world, 18,000 people. In designing it, we involved an online questionnaire. Young people said, we can't be bothered going even on laptop. Unless it's on our phone, mobile phone, we won't be involved in your study. And 80% of our recruits access the information sheet, the consent form, and the questionnaire on a mobile phone. That shows if we hadn't asked them, I'm 63 years old, I would have thought, well, it's on the internet. We gave them a QR code, so they didn't even have to type in an address. They said, we can't be bothered typing in internet addresses. If you give us a QR code, we'll scan it with our camera. So that's how you improve the design of your study. All of our research funders expect, if you don't have PPI, they won't give you the money. They'll just say, go back and talk to the public. I've mentioned the Health Research Authority's role in ethics committees in obtaining approval, and then setting up the study. When you've actually got approval, got the money, got the plan, actually setting it up, recruiting it on a hospital ward or intensive care unit, you need to involve the public at every single stage. And going forward, having learned from the pandemic, our aim is to ensure any researcher anywhere in the UK, in any subject, in any organization, university, charity, hospital, general practice, can involve the public and help them get help in designing research. So the last thing I'm going to do is talk about transparency. Sharifa, can you still hear me okay?
Yes, clearly.
And even when the Wi-Fi dropped, were you able to see the slides? Did my voice just drop, or did the slides drop as well?
It's just your voice, Professor, and the slide transition is great so far.
Okay. Well, I do apologize about the hospital's busy. Probably everybody's using Wi-Fi. Okay. This was a study done looking at whether trials were reported. You probably know there's a thing called publication bias, where editors like to publish studies. So vaccine we give to 100,000 children a year in the UK. This is a big thing. If they'd found the vaccine wasn't related to autism, Richard Horton would have published it. There's also was thought to be publication bias by the pharmaceutical industry, that if they did a study and it didn't show what they wanted, they would just bury the research. Why is this relevant to PPI? Well, I think the public, if they're involved in research, randomized trials, or they volunteer, I think we know from asking them, they expect that research to be published and shared with everyone, whether it's positive or negative, because that's the whole point of research. So these researchers from Oxford, I know Ben Kerr and Carl Hennigan, they did this research, and to their surprise, I think, and they were very honest, the pharmaceutical industry were really very good about publishing their results within 12 months of completing the study. The groups who were worst were the university researchers, and it varied by country. The UK was better than France, but even within the UK, for example, Dundee University in Scotland was much better than University College London, where I work. Now, all of these researchers, what this study in the BMJ showed, is we all owe a duty to our patients to publish our research, not bury it, because the reason they get involved in research is try and help us as doctors, nurses, pharmacists, physiotherapists improve our practice. And if we don't see the negative studies, how do we know? There was an editorial supporting this, which basically said reporting research findings to the participants. So never mind, what if they bury it, they don't publish it in JAMA or the Lancet or the journal Anesthesia, but they don't even share it with the people who were in the study, or thousands of people who give up their time, who perhaps underwent unnecessary endoscopy or scanning to try and find out whether a new treatment worked. And it didn't. The research is worth doing, but the result was you didn't need 3 endoscopies a year, you only needed 1. And it gets buried. That's you should with your partner. And then the clinical trials transparency. It was about the need for researchers, not just the pharmaceutical industry, that's pretty good, but for all researchers, when they complete their research, and for all editors to publish the research openly, open access, and to make sure everybody involved in the trial as a patient sees the research results. We had to appear before this and give evidence, and this is a letter to me from the chairman, Member of Parliament, the Right Honourable Norman Lamb, saying that thank you for appearing before them and giving evidence. And have we taken this on board? Well, this is the final slide. This year, we the date finishes, the date when you intend to publish. Then we're going to contact you 12 months after the end of the study. And we're going to find out if you published. And if you haven't, we're going to ask why. And we're going to ask whether you've shared your findings with the people you recruited to your study. And we will then publish those data. If they haven't published them in Lancet or BMJ or Anesthesia, we'll publish them on our open website. So I'm going to stop there, 6 minutes, if I can. And I do apologize that we lost the internet a bit at different times, but I hope you're all still there and very happy to take any questions.
Yes, we are all still here, Professor.
Good.
We do have several questions from the Q&A box.
Sorry, go ahead. It's my secretary calling me.
No
Yep,
worries.
go ahead. You go ahead.
All right, from a anonymous attendee. So the first question is, do you think the first and 2 years post-pandemic, the public would have renewed or rather increased interest to participate in medical research? Do you see that? Do you see that or foreseen that? Since you have mentioned that the interest is going down now during pandemic.
Yes, let me just get back to full screen so I can see you all. There we go. So I think your question is the public more involved in research, or is there, have I got your question right? Is there a greater willingness to be involved in research? Was that your question, Sharifa?
Yeah, so it's do you think that first 2 years after the post-pandemic, the public would have renewed or rather increased interest to participate in medical research? Do you foresee that?
Yes and no. So yes and no. So the public were very, very involved during the pandemic. And of course, you have pictures on the TV of people dying and people in intensive care. I have to be honest that trial recruitment in the last few months has fallen off a bit as people, as people are now starting to live with it. But I think we have learned many, many lessons. And I think over the next few years, if we forget SARS-CoV-2 and we think about other important illnesses, cancer, stroke, dementia, miscarriage, stillbirth, I think we have learned a lot from this that will help keep the public involved. Certainly, what I would say, it has increased the attention of politicians and the government to the importance of doing research, doing it well, and involving the public. And I think also increased the attention of the media, newspapers and TV, of the importance of research in answering these difficult questions. So yes, I agree.
Thank you. And since we're on that matter, there's another question on, does the pandemic actually compromise the quality of research?
That's a very good question. Well, it compromised it for sure in the sense I showed you that only 1 in 5 people did any PPI initially until we helped them. So I don't think that was, it wasn't deliberate, but it shows a preconception. It shows that people think the science is really important, the immunology, get the funding, but they somehow thought patient-public involvement was like, it's nice, it's an extra. It's nice if you can have it, but it's not crucial. We can ditch this. And actually, that's not true. And what I've tried to show, I hope repeatedly throughout this talk, is PPI is not some politically correct thing to, be nice to the public. It improves research. It means your recruitment will probably be higher. People are more likely to consent. You get less complaints. Your study will be better. So it's better for the public, better for the researchers. So I think that, yeah, there was. So where we were concerned about research actually wasn't so much with trials. There were quite a lot of applications for people to use confidential data. Now, many of those we accepted because we're in a pandemic. Normally, we're very wary of sharing patient data, breaching confidentiality. But we're in a pandemic. We have to get on with this quickly. And the government suspended some of the confidentiality laws. I won't go into the detail. We felt some researchers were perhaps, using this freedom to use people's data too easily. So yeah, there were some poor quality applications that wanted access to data that we thought, even in a pandemic, that is not appropriate. You don't need to know all of that about all of those people. But no, I think by and large, I think most of the research was high quality.
Okay, thank you for the answer. So I guess the next question comes from someone who's doing clinical trial. The question is, patient compliance is always a challenge in PPI. From your experience, how do you improve patient compliance?
Well, I've had the same experience as your questioner, where you think there's a beautiful slide that the chief medical officer shows. So when people apply for funding and they're asked for their recruitment trajectory, what's called the recruitment trajectory. So along the horizontal axis, you have months of the year, and the vertical axis is number of patients. So it always looks like this. And then a year later, they say, what was your recruitment trajectory? And it's always this, you know? So we've all had that experience. And the best way to ensure both recruitment, get consent, get them in, and then compliance, that they stick with your study and they fill in the electronic PPI, which we've been talking about, involve the public at the beginning. They will tell you, God, I wouldn't be in this study. It's far too complicated, too risky, too time consuming. So they'll tell you, you got to, and the second thing is this phrase, less is more. It's an architectural phrase, but we find, why do information sheets and consent forms get rejected? 12 pages of detailed writing. People think by giving more information, they're being helpful. They're not. The public don't have time to read it, and it has to be clear and honest. Still, a journalist has. If you read a newspaper, if you wrote a piece, Sharifa, in the KL Times today, and I've got to read 12 pages to find your message, I'm not going to read it. It's got to be a short, punchy paragraph that draws me in, but it's got to be honest. Can't hide the facts. So those would be the two things I say: improve compliance, involve the public from the beginning, find out what will put them off, and keep your information sheets and consent forms in plain English or plain Malay or Chinese or Indian, translate it into all your languages and keep it. I don't mean mislead the public. You've got to tell them the important stuff, but keep it simple and as brief as possible. And that's the best way to help compliance.
Exactly. We share that same sentiment, but the thing is, whenever a researcher or clinician have access to public, you want to get the most out of it. More questions and more bloods and more, tissue biopsies. So that's always been the case. So back to the question and answer on the Zoom from anonymous attendee. Perhaps not directly related to PPI, but in Malaysia, in the past 3 to 4 months, there have been a movement that they are pro-ivermectin as well as anti-vaccine. What are the best way to moderate or handle these people, as they have misquote and misrepresent research, as their points could be misleading?
Very good question. I mean, the first bit was there. I got their anti-vaccine. They are pro what?
Pro-ivermectin.
Sorry, pro?
Pro-ivermectin. The malaria drugs. Hello, Professor?
Oh, yeah, okay. But
okay.
Yeah, I understand. Yeah.
Yeah, the anti-malaria drug.
Yeah, we have the same problem. We have a lot of
Sorry, Professor, it keeps cutting off. And I think this is a very, very good question because it's still going on, to be honest. And anti-vaccine is quite active.
I think
Can
it's
you
a very
please
good
repeat
question.
that?
Well, so I'm going to kill my video to improve the bandwidth, okay?
All right, okay.
See if that makes it better.
Let's see if it works.
Let's see if that helps. So I agree this is a very important question. And we have the same problem in the UK. We have an anti-vaccination movement. Can you hear me?
Yes, perfectly.
Okay. So I think I would say I've listened carefully and I've learned two things from a professor of psychology in Germany called Wolfgang Geismeier. He says there's two groups of anti-vaxxers. There's the group that you will never persuade. They're maybe very religious. They believe God is against vaccines or their religion. You are never going to persuade them because they have a different belief system. But there's a group who are persuadable because they don't trust the government, they don't trust pharmaceutical, they think maybe the research hasn't been done well. The best way to persuade them is to use the public. They're less likely to believe, they won't believe politicians. They probably won't believe the government, civil servants. They probably won't believe journalists. They may not believe even researchers or doctors and nurses, but they will, if you can get other members of the public on side to help get your message across. Look, I had a child die of polio or dengue or malaria. My second child was vaccinated. They survived. That's a really, really powerful message, you know, from somebody who's a parent who's, my child died of tetanus, my first child. They died of pneumococcal pneumonia. They died of meningococcal disease. My second child is alive and well. That's going to be powerful. I think, so that would be but it's a big problem. Anti-vaccine movement, very big problem in France, bigger than in the UK.
Yes, exactly. Hello, did we lost you there?
No, I'm still here.
Okay, you're still there. All right. Yes, yes.
Do you have any more questions?
Yeah, there's actually the third question from Sheng Hui Young. Based on your experience, how do you involve patients in designing clinical service studies while maintaining a professional doctor-patient relationship? Where do you draw the line in terms of ethics?
Okay, these are great questions, and I should have addressed all of these in my talk. So we wouldn't use, if possible, we don't start with the patients who might be in the trial. So we would have PPI groups. So I'm a pediatrician. We have a group of young people and carers, and it constantly changes as the young people become adults, they have to leave. Who are not, so let's say at the moment, I was doing some research on type 2 diabetes in children, increasingly common with obesity, but not very common. So we don't start with them. We started with a group of just healthy young people and said, are you aware of obesity? Are you aware of type 2 diabetes? We're thinking of doing some research. Do you think this is important? This is how we're thinking of doing it. They gave us a lot of input about, in that study, about the sort of questions you might ask about diet, about school, about who cooked the meals, about who did the shopping. They were healthy young people. And then after we've done that, we start to move on to ask young people with diabetes. They're still not the people we'd ask on a research. And then eventually we do the research. Now, sometimes you can't do that. So the mentions research, I give the example of difficult to implement, you may have to involve their heroes.
Sorry, we lost you just now.
No?
Yeah, we lost you a little bit just now. Can you repeat what you just said?
So dementia is an example of where maybe you can't use the patients because they don't understand you. But if you were to do research on rectal cancer, then
Sorry, we lost you again.
thing saying is you don't have to use people who you're going to recruit to your trial. You do the pilot work, PPI. You don't involve people you're recruiting in the design study. Is that come?
No, sorry. You know what? We did not get the gist of it. The question. What would help if you can type it on the chat session, Professor? Maybe our audience can read it.
No, I can't get access to the chat.
Oh, you can't get access to the chat?
No, I can't. It's no control. No, my options include I can mute my audio and hide my video, and that's about it.
You can only see. Oh, now you can.
Let's see.
Hold on, yeah.
No option to type. Can you hear me now?
Yes, now we can hear you. Why don't you try to explain that again?
Okay, I'll keep it short. What I'm saying is you can involve patients in public before you do don't involve the people who are going to be in your trial to do the PPI. you involve some people, you help design the study, but they're not the people you're going to recruit. That way you avoid that ethical question of a conflict of interest. You approach some people who've survived colorectal cancer and say, this is the study we want to do. You get their input. And then when you start recruitment, you don't use them, you recruit a new population.
Okay, all right. That's a really good input on that. And the last question on the matter of transparency and publication, because it is very important, for researchers to publish. But how impactful it is to publish a scientific research, a scientific article, if there's no value or for the lay audience to understand? Do you think that it should be made mandatory for each and every research that's involving patients to actually come out with a pamphlet that is easily digestible for the patient, for the participants after?
Yes, absolutely. Another great point. There's no point in sharing information with the public if they can't understand it. So in all of our now research grant applications, in all of our English speaking, in English publications, you will be asked to write a lay summary.
Oh,
And
so
again,
it is a requirement. Okay.
Requirement, and it will be sent back to you if they give it to a non-expert to read. If they don't understand it, it doesn't matter how good your research is, it'll be sent back. They'll say the public didn't understand it. So that's a very good question. Essential.
Brilliant. That would be, that would serve the purpose, giving back to the public and educating them at the same time.
Sharifa, could you do something for me?
Yes, of course. What is it, Professor?
If you could email me, these questions have been fantastic, and I would like to incorporate them into the next time I give this talk. There was a question about the conflict of interest of using the patients. There's a question there there's been a question about lay summaries. There was a question. The questions have been fantastic. If you can cut and paste the chat into an email and email me, I'd really like to put them into my next time I give this talk, because they've been really, really, really good questions.
Of course, no problem. We'll be happy to do that for you. Definitely, we'll email you. Thank you so much, for sharing your experience and for sharing, all this research that's been going on in the UK. And I hope not only our researchers and science, and clinicians here get the gist of it, but I hope that our public members that's watching on YouTube also realize the importance of public engagement and public involvement in research. Thank you so much for sharing with us, Professor. Oh no, you're muted. Sorry, you're muted.
I just said thank you for inviting me.
Okay, all right.
Please, you have to copy and paste the chat before you finish the Zoom, because I think it disappears. So make sure you've got a copy of it before, because I would really value the questions were fantastic.
Definitely, don't worry. We have a whole team right here with me. Yes, in the room to make sure that all the questions are being recorded.
Good. And at least you saw the slides, even you couldn't hear me. That's and I'd love to come back to Malaya soon. I haven't been back to Malaysia for maybe 10 years. So and maybe when COVID's
that's way
over.
too long. You should come over. You should come by.
Well, you'll have to invite me to your next research carnival when it happens for real. Then we won't have this Wi-Fi problem. I can be in
of course.
I can be in KL with you. Okay.
Of course, definitely. Hopefully next year we can conduct something similar to this. Thank you so much. So to our audience, before we end the session, I would like to thank you for your participation. Thank you so much. Okay, so before we leave and before we end the session, it's just a little quick sneak peek of tomorrow's session. In order to commemorate Breast Cancer Awareness Month, we dedicate the whole morning session to discuss on PPI and breast cancer early detection and survivorship. You can see there's a broad range of researchers, NGO, patients, public members that will be joining us tomorrow morning, and they will be sharing their experience in PPI and also the research around breast cancer. Okay. Thank you so much, everyone, and thank you to all of our speakers for sharing your insight on PPI from a very holistic aspect. So we hope that we'll see everyone tomorrow morning at 9. And thank you so much. And don't forget to sign in your attendance in order for you to get into the lucky draw. Okay. Thank you.
Bye-bye. Thank you.
Thank you, Professor.